There are some very, I think, important studies that I think are going to be practice changing, and I want to highlight in particularly two of them. One of them relates to CAR T cells, and we've known about CAR T cells in hematologic malignancies in general, and some of them are approved already. But I want to highlight this study called the ZUMA-3, which evaluated one of these CAR T cells called KTE-X19, which is an anti-CD19 CAR T cell. And in this study, it was investigated for patients, for adult patients with acute lymphoblastic leukemia. This cellular therapy is approved for mantle cell lymphoma in the United States. But in this study, they included adult patients age 18 or older with refractory or relapsed acute lymphoblastic leukemia that had evidence of disease, 5% blast or not. So these patients received a conditioning regimen with fludarabine and cyclophosphamide, and that was followed by infusion of these CAR T cells at a dose of 1 times 10 to the 6 cells per kilogram. The primary endpoint was the response rate, and this was defined as CR plus CRI. Now, one important thing to follow is the flow of the patients, because of course, not everybody that we want to give these cells, we can. For example, here they enrolled 71 patients. They were leukapheresed. Then they end up giving chemotherapy to 57. Some dropped off, some because of adverse events and other things. And then they eventually gave the cells to 55 patients. So it drops from 71 to 55. We need to acknowledge that some patients at some point are not able to get the cells. This was a patient population that, again, 55 patients are described. These patients had been very heavily pretreated. The median number of prior therapies was 2, but there were some patients that had received 8, and almost half of the patients had received at least 3 prior lines of therapy. And the response rate was quite remarkable. It was 71% CR plus CRI, most of these being CRs, 56% the CR rate, so just a few others. And then there were some other responses that we could claim as a favorable outcome, not the primary endpoint, like blast-free bone marrows in 7% of the patients. And the other important thing is that this extends to really all the disease and patient characteristics. They analyzed different subgroups, and all of them looked very good. And the response duration was also quite good. The median response duration of overall was a little over 1 year. So it is I think very attractive, and the overall survival ended up being then very good, particularly for patients who achieved a response. The remission, the overall survival has not been reached. So I think this is a very important report. Well, and before I move to that, I want to remind you that there is some cytokine release syndrome. It was present in about 90%, but it was only 24% grade 3 or 4, and some neurologic toxicity, 60%, but only 25% grade 3 or 4. They had good management of these, and I think we've learned that if you identify these early and are aggressive on the management, for the most part, these can be controlled. Of course, there are some that can be very serious, and we need to acknowledge that. But this is a very important study, I think, and actually this is being evaluated by the regulatory authorities, at least in the United States, for approval, and it may be the first CAR T cell for adult acute lymphoblastic leukemia. We have some that have been approved for adolescent and young adult, but I think extending it to adults with acute lymphoblastic leukemia will be very valuable for these patients. So I think this is something we need to continue following the story, it is an important development in our treatment of acute lymphoblastic leukemia. The other study that I want to highlight, because I also think that this is potentially practice changing, is in a different setting. This is adult patients with Philadelphia positive acute lymphoblastic leukemia. And of course, we've learned that those patients historically had a very poor prognosis. Then TKIs came, and that has improved the outcome of these patients. We've used first imatinib, then dasatinib, then ponatinib with chemotherapy, and that has improved the outcome and really offered the possibility of survival without even transplant for many patients. Survival rates have been described in 60% or higher. But this study looked at a combination of ponatinib and blinatumomab, no chemotherapy. So these patients receive ponatinib initially at 30 milligrams daily and 4 weeks of blinatumomab, 2 weeks rest. Then they go to a consolidation, which is the same kind of sequel, except that the ponatinib dose drops to 15 milligrams, and they receive 4 cycles of that, of consolidation, and then a maintenance of ponatinib. They do have, it's a relatively small study still with only 35 patients, and there's some that are frontline, 20 patients, some that are refractory or relapse, 10 patients, and 5 with the lymphoblast phase. So still small cohort, small study, but the results are very attractive. First, the median age of these patients was almost 60, 59 was the actual median age. So it's an older patient population, but the results are, as I mentioned, very good. The CR rate overall is 89%. It's 93% for the front line and 89 for the refractory relapse. And very importantly, transcripts are undetectable. The BCR-ABL transcripts are undetectable in almost 80% of the patients overall. And this is across the board, perhaps a little bit less. The one that drives these down a little bit is the blast phase CML. But in both the frontline ALL and the relapse refractory, it's 85% plus. So as you can imagine, with these results, the overall survival, the event-free survival is outstanding. 2-year event-free survival is 70%. 2-year overall survival is 80%. And in the frontline cohort, these rates are over 90%. This is outstanding. And again, knowing that this is going to be without chemotherapy, it offers really great possibilities for these patients. Also very important is that we know that there's some neurotoxicity with blinatumomab, but there was very few instances of these with this regimen. They only described 1 grade 3, 0 in the lower grades. There was only 2 patients with cytokine release syndrome, both of them grade 2. So really looked like a very well-tolerated regimen. They also didn't have any significant arterial occlusive events, important with ponatinib, perhaps because of the lower dose. So very, very valuable approach without chemotherapy. Very briefly, I want to mention a couple of studies. One of them is a report on the incidence of veno-occlusive disease after transplant of patients that receive inotuzumab. Inotuzumab is another very good drug for ALL. The concern has been the possibility of developing veno-occlusive events. And so it sometimes is a concern because we use inotuzumab and we want to consolidate that with a stem cell transplant. But this is a registry-based observational study, so it reflects more of a regular practice kind of setting, which is important. And and what they described is that the overall incidence of veno-occlusive disease is somewhere around 15%. It was in refractory relapse acute lymphoblastic leukemia. was 18%. So it's a relatively low rate. It is something to keep in mind, but I think it is something that's very doable. And considering the prognosis of these patients without adequate treatment, I think this is very valuable. And the non-relapse mortality was fairly low in that regimen. And then the other observation that and this is something that we know, but it's important to highlight the value of assessing MRD on patients. This was a study in adolescent and young adults, and they assessed all their patients at the end of induction, then after consolidation, then at the end of treatment. And they again showed the significant benefit of MRD negativity. So for example, the disease-free survival for patients with MRD negativity at the end of induction was 83% compared to 72% if they have measurable residual disease detectable. And then at the end of consolidation, it is around 75 to 77% if they're negative versus if it is positive or more than 0.01. That's a cutoff that was presented. It's somewhere between 55 and 70%. So clearly, there's a value of MRD that is our common practice today, but this just further emphasizes. And the one thing that was included in these studies that they assessed it both in standard of care and in an experimental arm. So it extends across the board. So important, perhaps not totally novel information, but I think it is important to keep in mind that this is something we need to see with our patients. So I think exciting to see that there's so much movement in acute lymphoblastic leukemia, including some really practice-changing approaches. Thank you for your attention.